Have you ever watched a battle between AlphaGo and human professional Go players? AlphaGo is the first computer program developed by DeepMind Technologies, became the first computer program to defeat a world champion in the game of Go back in 2015 and 2016. That was already a few years ago. Artificial intelligence, or AI, has now evolved even further. AI can play golf with and against human golfers. AI from IBM has been successful at debating human opponents in variety complex subjects by researching a debate topic, creating claim points, and even crafting reviewers against a human's point of view. It is quite impressive and mind-blowing. Can you believe that AI now can assist a human physician's colonoscopy in making colon cancer screenings more accurate? It is called AI colonoscopy, which was invented by University of California, Irvine and DocBot scientists. DocBot is a privately held medical informatics startup that has been developing AI-assisted digestive care solutions since 2014. So what is this AI colonoscopy? Is it a robot or a computer program or a device? Let's figure it out. I'm your host, Dr. Shin. Welcome to my Science Cafe. I'm truly honored and very excited to introduce today's distinguished guest, Dr. William Karnes. Dr. Karnes is a clinical professor of medicine at UCI, director of high-risk program and colonoscopy quality at Child Comprehensive Digestive Disease Center at UCI Medical Center. He is also a co-founder and the chief medical officer at DocBot. Welcome, Dr. Karnes.
Thank you so much, Grace.
Okay, so what is DocBot's AI colonoscopy? Is it a robot or computer program or a device? What's the difference between AI colonoscopy and the traditional regular colonoscopy?
What it primarily is, is a device that is observing the video stream from the colonoscopy and picking out features that we have taught it to find for us and to characterize those features for us. The whole idea is to think of it as your professor sitting on your shoulder, helping you and guiding you during the procedure to find more polyps, for example, because polyps are the precursors to colon cancer. We don't want to miss any. We want to remove everyone that we find, and that dramatically reduces the risk for that patient to get a colon cancer in the future. So that was one of the #1 things we wanted AI for colonoscopy to assist us with, because not all colonoscopists are the same. We estimate that about half the population over age 50 have at least one precancerous polyp in their lifetime. And our adenoma detection rate, in other words, the rate at which we find these precancerous polyps on a per person basis, is under 50%. So we don't find all the polyps that are there.
Wow, that's surprising. I thought physicians find out all polyps at one
Not
single
all colonoscopies are the same. So colonoscopists can range in their adenoma detection rate from as low as about 7% to as high as over 50%. So some really do achieve an equality between their adenoma detection and the true prevalence of those adenomas. And we also know that for every 1% increase, we can improve our ADR. There's a 3 to 4% decrease in the risk that that person's going to get a colon cancer before their next colonoscopy.
Wow. So would you describe ADR for our audience?
Yes. So if you scope 100 people and you find at least one adenoma in 30, then your adenoma detection rate is 30%.
Aha. Okay, okay. So basically, humans are not perfect. So even though well-trained GI physicians, the detection, they gonna miss some of the polyps that's important or that's cancerous.
Correct.
Correct.
Thank
Do
you.
you have anything else to add to that area, or can I move to the next
You
question?
can move on. Sure.
Okay. So, Dr. Karnes, according to the American Cancer Society report, colorectal cancer incident rate dropped significantly due to screening, particularly in people over age 65 who qualify for Medicare, which makes colon cancer screenings available for free. However, despite all that effort in spendings over 20 billion per year on about 90 million colonoscopies, colorectal cancer remains the second most common cause of cancer deaths in the United States in men and women combined. So why is that? Will AI colonoscopy be able to help tackle that problem? What is the main advantage and benefit of AI colonoscopy for physicians, GI specialists like you, and for individuals like me and our audience?
Well, it's a multi-phase question. So we've seen a 30% drop in the incidence of colon cancer in the screening age population, while we've seen a 20% increase in the under screening age population, so the under age 50. So we know that screening with colonoscopy reduces the risk of colorectal cancer. And then part of that is also related to the quality, as I mentioned before, of the colonoscopists themselves. You know, how well are they finding your polyps? Are they truly leaving no polyp behind when they do their colonoscopy? So yeah, the impact of colonoscopy is significant. AI potentially could improve the effectiveness of colonoscopy by leaving fewer polyps behind.
Thank you. So how many AI colonoscopy procedures have you done so far? And how many total AI colonoscopy procedure data does DocBot have now?
Oh, that's a good question. I don't know the exact number, but we've been running AI under an IRB protocol at UCI as an investigational device, basically, for 2.5 years. I try to do AI on every one of my colonoscopies. We have AI machines in most of the rooms, and I would estimate that I've done 1,000 with AI
For the last 2 years.
for the last couple of years.
Wow.
And this is all part of an interface improvement study to get our algorithms working really well so that they're ready for multi-center trial, which DocBot has now started.
Okay, so I have a couple of questions related to that. So you mentioned the DocBot's AI colonoscopy is an investigational device. So so it seems likely the FDA encourages AI technologies and has already authorized a number of products as medical devices in recent years. And first of all, congratulations, Dr. Karnes and your DocBot team, that DocBot's AI colonoscopy device receives a breakthrough device recognition by FDA. So you mentioned like DocBot's AI colonoscopy is an investigational device still, but because of this FDA's breakthrough device recognition, you can do more than uh, just the investigational research purpose only. So would you, first of all, would you tell our audience what this FDA breakthrough device recognition is and what you can do under this breakthrough device recognition? For
Okay.
example, like insurance coverage and etc.
Well, the breakthrough device recognition is for a different AI that DocBot developed along with investigators at UCI. It's for finding dysplasia, which is a precancerous change in a condition called Barrett's, which is of the esophagus. So Barrett's occurs in people who have had a lot of reflux and heartburn. Barrett's has the potential to turn into cancer. The risk of that cancer depends on how much Barrett's you have in your esophagus. And one of the really difficult things for physicians is to look at Barrett's with their naked eye and say, well, where am I going to target my biopsies to see if there's any dysplasia here? Now, the experts are really good at it. They can recognize these very subtle changes in the mucosal pattern that tell them this looks suspicious and I'm going to biopsy this. But most endoscopists out there don't know how to recognize those subtle features. And what they do is random biopsies of the Barrett's in an attempt to hopefully find some dysplasia if it's present. So using the expertise of Dr. Samersina and his team, he was able to go in and look at all these videos of Barrett's and highlight the suspicious areas, train the AI to recognize those sites. And that's our breakthrough device.
Wow. Is that covered under Medicare and other private insurance for that procedures as well?
It's not FDA approved.
Okay.
It's also going to require a very large multi-center study. And we're still in the process of training it well enough so that we're all really happy with its abilities to do what we want it to do. And Dr. Samersina is busy getting together a bunch of centers around the country who have experts on Barrett's and Barrett's dysplasia to make this thing happen.
Okay, so how long do you think will it take to do the multi-site clinical research, clinical trials, and get an FDA approval for that breakthrough device that you mentioned?
I think once we have the consortium together, we already have the protocol that we'd like to do and everybody's in agreement with it. We should be able to get that data within a year or two once that clinical study starts and get approval for it.
So how many participants you usually need to prove that AI device is effective?
Good question. It's all about powering the study to show benefit and comparing it to a standard of care. And I'm not a statistician, and I can't really tell you how many Barrett's cases they're going to have to do. Dysplasia is relatively uncommon in Barrett's, and so they're going to have to look at a lot of Barrett's cases to kind of pull this out. And that's why we need all of these specialized Barrett's centers to be participating with us. But I don't know how to put my finger on the exact number. For something like adenoma detection rate, those numbers are pretty straightforward. You need about 700 to 1,000 people split into the two arms, AI on, AI off, to really get at the power to find a statistically significant difference.
Okay, so keep us informed because this is very important and very exciting news to us because AI technology improve accuracy and detection rate and identify cancerous polyps and cancerous dysplasia, that's really important and great news for us. So please keep us informed. So
Certainly.
you mentioned there are other sites. I know that UCI Child Comprehensive Digestive Disease Center offers Doctor's AI colonoscopy, and you operate over there, in as well as the traditional regular colonoscopy. But you mentioned there are other sites involved in this AI colonoscopy as well. Can you name some of those sites, and if someone and anyone is interested in getting AI colonoscopy, and if so, what is the best way to find the information about which location offer their service, and can Medicare or other insurance covers, and how to make an appointment, how to request an appointment,
Good question.
etc.
So the sites we have now with our multi-center study, there are several. Most of them are large, either multidisciplinary groups or large GI groups, such as GastroCare. In Alabama. We have a large group in Washington, D.C. We have a group in Virginia. We have a group in Minnesota. One of the largest groups are in Wisconsin, I'm sorry, participating. We're recruiting more sites as well. It's a good question. If somebody really wants to travel across the country to go find and participate in one of these studies, they're not going to know whether the AI is going to be on or off for them, because that's going to be randomized. But I think, we could provide information related to that, whatever's closest to home. I'm not sure how we would arrange for that contact to occur between a patient and a center, but
Yeah, I think just knowing the information which centers can offer, because then people, that's kind of our decision whether we want to go and participate that research study or not. But it's a good information for the people to know about it. And so let me clarify a few things. First is the UCI offers, UCI Digestive Disease Center offers AI colonoscopy. Is it covered by insurance or not? Not yet.
Oh, it's there's no extra cost related to its use under investigational care or investigation. It's just, if they want it on, it'll be on. If they want it off, it'll be off. And that's just a flip of a switch on the monitor. So yeah, does that answer your question?
Yes. Okay. So people, so for example, if I'm interested in getting an AI colonoscopy, I just call the UCI and say, hey, it's my time to do the screening colonoscopy. I want to do the AI colonoscopy, then that's it, right? Because in my insurance covers traditional regular colonoscopy, and that also covers if I choose to go
Yes.
AI colonoscopy.
Yeah, that's uninvolved in any insurance or any costs to the patient.
Wow, that's good to know. That's good to know. Okay, thank you so much.
Yes.
And my next question is related to the fact you mentioned earlier on. You mentioned like the surprisingly the colon cancer is rising younger adults younger than 50. So you may remember the late Chadwick Boseman, who the movie star of the famous movie Black Panther. He was
Yes.
diagnosed with colon cancer at age 39, who sadly passed last August 2020, at age 43, following a 4-year battle with colon cancer. So I saw some of the articles published and mentioning it is a trend now that colon cancers in younger folks, younger than 50, but even sometimes 20s and 30s. So, Dr. Karnes, that is the type of colorectal cancer diagnosed in those young adults younger than 50 different than that of an older adult? I mean, in terms of molecular profile, signs and symptoms and locations, are they different than younger ones in the cancers in younger ones in colorectal cancers in older generations? What are the risk factors for those um, early onset colorectal cancer?
That is a really good question. So the cancers in the younger population tend to be more left-sided, in other words, more distal in the colon, toward the rectum and the sigmoid area, relative to the older onset colon cancers. The molecular pathway seems to be, in general, the classic chromosomal instability pathway, which is the most common overall pathway toward colon cancer. In terms of risk factors, it's one of the things I'm really keen on getting an answer to, because right now screening is determined by age. It's determined by family history, and it's determined by what's been found in your colon before. It doesn't take into account, it does take into account race to a certain degree. For example, African Americans are more likely at a younger age to get colon cancer. That was recognized 10 years ago. And so the screening starting age for African Americans was 45 instead of 50. As you probably know, the American Cancer Society and now the American College of Gastroenterology is endorsing the idea of starting everybody at age 45 if they're average risk for colon cancer. So that's, that takes care of the primary risk factors, but there's a number of things that put us at risk for colon cancer related to our lifestyle, whether we have diabetes, are we obese, do we eat too much red meat or processed meat, are we drinking too much, smoking too much? And those factors don't really go into any calculations on when somebody should start, but they could have a wide swing in your risk at whatever age you are. So one of the things that we would like to do with AI is to collect data on people from their electronic medical record, maybe their genomics, and then with the colonoscopy outcome, to use that outcome as to whether they did or did not have cancer or precancerous polyps, to create a risk model using artificial intelligence where it might distill down to maybe 4 or 5 questions you could ask somebody that says the probability that you have a precancerous polyp right now is X%. And that X% is high enough that we should do a colonoscopy now, even though you're 38 years old.
Wow. I think that's an excellent point in future direction, because the age guidelines for colon cancer screening seems likely did not account many other factors. And because the national trend that like a younger adults younger than 50, now they start having colon cancers, and that affected by lifestyle factors, as you mentioned, like a diet and exercise and everything affects. And so I in my communities in here, we already experienced that too, because someone see and experience their something's wrong in their stores and something's wrong in their routines. So she talked to a physician, but physician mentioned like you are too young for the colon cancer screening. So she was seeking non-insurance paid colonoscopy, and there was a cancerous spot found. So what symptoms and um, the signs we have to pay attention, and we have to seek help and further help? What is it?
Well, there's a really important thing that I want to get across to everybody, and that is that polyps don't cause symptoms.
Oh,
Cancers do cause symptoms once they're large enough or to actually cause a symptom, whether it be bleeding, whether it be that it's causing your stools to be thin, it's causing abdominal pain, it's causing a change in your bowel pattern. Um, and unfortunately, if you wait for symptoms, about half the time the cancer is already advanced. And that's the importance of screening. And that's what makes it so unfair that people can't be screened at younger age. But you don't want to overburden society in the costs of screening by screening people who are extremely low risk. And that's where predictive models are so important.
okay. So that's such a great point. So if we wait, because polyp didn't generate any symptoms or signs, but it advanced to become a cancer enough, then we feel something or blood in the stool, but that's already late. So that's already late. So you recommend, so it really put colonoscopy screening into the position. We have to do the screening, follow the guidelines, but younger folks, we cannot do the screening. They cannot do the regular screening because of age guidelines. That, so in that case, do you think the participating clinical research that you and your other colleagues lead, isn't that another way of a solution?
Yes, yeah. So we have already worked with what we call the Epic Data Warehouse team, where they have collected all of the electronic health record data on everybody who's come through UCI. It's
Any age ranges?
all ages, anybody
All
and everybody.
ages. Okay.
And it's all de-identified, but linked to the outcomes of colonoscopy. So we're in the process right now of actually getting that data into a format where we can start running this algorithm, or using the machine learning to see what the key factors are in predicting that. So I'm really excited about that. Another point is that colonoscopy is not the only screening test. So it is the only test that we have that can really find polyps. And it's the only test that can remove a polyp at the time it's found. So that's why it's so effective for prevention. But the newer stool tests like FIT tests, which can detect the minute amount of human blood in the stool, are very effective at finding cancers before they cause symptoms, which puts you in a much lower risk category in terms of how advanced is that cancer going to be, and can a surgeon just go in there and take it out and you're cured. So FIT testing, particularly for average risk people, people that don't have a family history, they've never had polyps before, they have no symptoms, is a very reasonable thing to do. Again, though the starting age for that, according to the guidelines, is still 45 or 50.
Okay. Thank you so much. So how much the family history or the genetics play a role in here?
Huge. So if you have a first degree family member with colon cancer under the age of 75, your risk is about double what the average risk person's is. So the average risk in the United States is about a 1 in 20 to 1 in 25 chance you're going to get colon cancer in your lifetime. It's going to be 1 in 12 or 1 in 13 if you have a first degree family member. If you have multiple family members, particularly on one side of the family where the gene is kind of carried through, if there, suggests that there could be a gene carried through from great grandmother to great grandmother to grandmother to mother to you, then you start thinking about genetic syndromes. And Lynch syndrome is the most common. 1 in 300 people have Lynch syndrome. And it's estimated that 80% of them don't even know they've got it. And they're unaware of their very high risk for colon cancer in their lifetime, which could be over 50%. And screening for Lynch syndrome starts at age 25. So if you have that, if you're known to have the syndrome with genetic testing, then you start at age 25 and you do it every 1 to 2 years from then on out.
Wow, that's good information. And is there any difference between gender? Like man has more prevalence in colon cancer than woman, and Lynch syndrome more in the man's side or the woman's side? Are there any differences?
No, Lynch syndrome is an equal opportunity provider. So
Okay.
it doesn't matter whether you're a man or a woman. It's just that Lynch syndrome can also cause ovarian and uterine cancer, which men don't get. Um, um, with respect to sporadic colon cancer, where there's not a specific gene, where it's just acquired because of our time on the planet, men are slightly more likely than women to get colon cancer and die from colon cancer.
Okay. So, any advice for our audience for better GI health, except
Exercise.
including the screenings and a stool test, the fit test, and genetic screening if you have a family history? Other than that, any other devices?
Yeah, lean and mean, eat well, stay away from too much processed meat and too much red meat, don't smoke, and minimize alcohol, to moderate or lower. Those are the key things. Exercise.
So the basic rules for everyone in every condition, right? So
What
that's
helps
the
your
very
heart
basic
helps your
one. Help
colon.
your yes.
Yeah.
Okay. So let me switch the subject. So Dr. Karnes, you are a physician, so you see and treat patients as a GI specialist and scientist. So you conduct the research, your own research, and entrepreneur. So would you share a little bit about yourself? Like, did you always dreamed of being a physician, scientist, entrepreneur, or did that opportunity at DocBot come naturally later? What motivates you to become a GI specialist in GI health field, and what training did you take, and what makes you interested in AI technology and bringing in that AI technology into the clinical practice?
Wow. I've always been very curious. I've always wanted to know how things worked. When I went into medicine, I always chose a path that would leave my most options open until that passionate area kind of found me. And, I loved cardiology and I loved GI. And it was primarily the other gastroenterologists I met that made me fall in love with gastroenterology. The other thing about gastroenterology is that not only do you have to listen very carefully to your patients and figure out what possible things could be going wrong to explain their symptoms, but you have to think and you have to care, but you also get to do procedures. And I love doing procedures. Um, but trying to figure out how things tick, I became very passionate during my fellowship at UCI in colon cancer, growing colon cancer cells and figuring out why are they growing autonomously. I take a normal cell and I put it in a petri dish and it dies after 10 or 12 cell divisions. It just dies. I take a cancer cell and I put it in the petri dish and it will divide forever. And trying to figure out, what is the mechanism? Why is that all happening? And that's kind of where I started with colon cancer and did primary research there when I was at the Mayo Clinic. It was all lab-based research. And then went into private practice and became really obsessed with preventing colon cancer at a clinical level. And then when Dr. Chang asked me to come down to UCI to wipe out colon cancer in Orange County, I came down and I said, okay, well, here's some things we need to do. And one of them was to collect data so that we could monitor our quality. And that was the colonoscopy quality database that I set up in 2012. And then lots of data in there, lots of pictures of polyps, lots of all this. And we were able to give feedback to all of our colonoscopists about what their ADRs were. And that brought their ADRs up by giving them feedback. And then met Andrew Nin, our CEO, about 5 years ago, I guess it was. And we said, we need to create this for everybody, because the amount of data we're going to have and how much information we can get from it is going to be amazing for preventing colon cancer. And that's how we started, until we realized at UCI was the only place where the nurses would put in this data for us in real time during colonoscopy. When we tried to take this out into the real world, it wasn't going to happen. And that's when the light bulb went off for both Andrew and I. Now we have all this data, we could train AI to do all this for us. So the nurse doesn't have to put it in. I don't have to put it in. AI can see it all and put it in for us. So that's how the light bulb went off. That was my first venture into being an entrepreneur. I had no interest in doing that before.
Oh my. So I'm so touched, because this is entrepreneurship and setting up the company AI. That's not your original plan. You want to be a physician and scientist, really care for your patient and to make a better diagnostic and better treatment options for everyone. That leads you to become an entrepreneur, and that really make a big circle, right? Because then the new technology help physicians and scientists work on that project. So I'm so impressed. Thank you. And Dr. Kans, there is a saying that having the right startup team is half the battle. I think that is very true. And you have an exceptional team at DocBot. And you mentioned Andrew Nin. He is the CEO. So I'm curious, who's in your team and how you meet them? How did you meet and find them, find your co-founders and members? How did you know that they were the right individuals to partner with?
Well, Andrew and I hit it off immediately because, we had the same vision. He had the tools to actually make it happen. I had maybe the vision on what I wanted it to do, but no skills to make it happen. And so we were a perfect match. And as it turns out, his best buddy all the way through high school is an amazing computer engineer. And, it didn't matter whether it was hardware or software, he could do it. He could do it all. So what we needed, though, was a good AI expert to help us out. Andrew had a lot of experience with machine learning in other aspects of his prior life. And keep in mind, he was only 19 when I met him.
Wow. So he was a college student.
No, he didn't even go to college.
Oh my, he is truly
Yeah,
genius in that field.
right. Yeah. And we've heard that story before, right?
Yes. Wow. So how many DACPO team members you have?
It's grown tremendously over the past month and a half. We brought in a new CEO who was kind of a seasoned veteran in the health area. His name is Andrew Ritter. So now we have two Andrews.
Two Andrews.
And he was highly successful in bringing his startup company out to IPO and then sold. and then was looking for something new and exciting to build. And we interviewed him along with many other CEO candidates. And he came on, took the bull by the horns, learned everything really fast, was able to secure additional funding from venture capital, and now he's working to hire a whole bunch of engineers and other support people for the company. So I don't even know how many we have right now, but it's probably a dozen, maybe.
Wow. So, what is DARPA's plan for near future and long-term goals? Seems likely you guys are ready to move forward and fast. So, would you share what's your plans?
Yeah, it's kind of what's the best model? Do we just make boxes with AI built in and then sell those boxes? Um, or do we try to be providers ourselves? One of the things an AI company needs is data to keep getting better. And it's hard to get data if you don't own the data. And so, one thought is maybe we should get in the provider business, like in ASCs, ambulatory surgery centers, where we're DocBot powered ASC. Where DocBot is powering everything from the patient interface to collecting the clinical data, to observing the endoscopies and all of that, and then have AI continuously get smarter and learn from that. And that's kind of the new way that we have approached this to be viable and to thrive.
Wow. Best wishes. And Dr. Kans, thank you so much. Thank you for taking your time and sharing your insight and recent advances in AI technology in GI care. So, colorectal cancer disproportionately affects the American communities of color, and 52% of Asian American adults between 50 and 75 years old have never ever been screened for colorectal cancer. So let's change that. Let's
Yes.
change that. Do not put off your screening colonoscopy. Let's start schedule a screening AI colonoscopy with Dr. Kans right now. And let's change our lifestyle to make our body healthier and reduce the risk of getting colorectal cancer at the later life.
So one of the, I'm sorry.
Go ahead. Go ahead.
There were really 3 arms to wiping out colon cancer in Orange County when I came to UCI in 2012. One was to collect all the data, which we've talked about. The other was to create the high-risk clinics so that the Lynch syndromes and the other genetic syndromes had a home at UCI to take care of them and make sure that they don't get cancer. And the third was, how do we reach out and make people aware? Because I think, sure, there's always people that are going to say, I don't want a colonoscopy, but would be willing to do a fit test. I mean, that's easy. But they don't know. They haven't received the education or the knowledge. They haven't been provided an opportunity to look at their risks and what could be done when they change certain things in terms of, what does that do to their risk longer term? And so the third arm of this was to create some kind of an app where it would be simple to fill out. You just put in a few things and it tells you what your risk for getting colon cancer is, what the risk that you have a polyp right now is. And then you can say, oh, well, let me just change this from smoker to non-smoker. Let me change this from, all this red meat to more, replace this with salad. Let's bring my BMI down from, 32 down to 27 or 25. And oh, look at my risk go down. And then they say, well, let me see what happens when I say colonoscopy. And they click colonoscopy and then the risk goes, pew. So, something like that, that's interactive, that is kind of self-teaching in a sense, is the idea. And that, we haven't developed that yet, but you know, once we get this machine learning thing, this predictive model going, I think that we're going to be well on our way to making something like that.
Wow. Oh my God, that app gonna be amazing tool to educate as well, because that app, if it's developed, we can
Mhm.
clearly see what's my risk factors and how I can reduce it. That's amazing. So I look forward to seeing that app in action in a couple of months or so.
Well, we don't have a team working on that one just yet, but
Yeah, but I look forward to it. And so the audience, if you are interested in learning more about DocBot's AI technologies and new seminar information or any new research updates, follow Dr. Shin Science Cafe at X Media. Thank you, Dr. Kans. Thank you again.
thank
And
you guys.
audience, stay tuned.
Thank you.
So, Dr. Kans, if
Mhm.
you want to share the video and you
Mhm.
like to explain some points,
Mhm.
you can do it now and then they can edit it later.
All right, let me open that up for you.
Sure. Then I can put you as a co-host so you can share. Give me 1 second. Okay. I'll put you as a co-host. Okay. So feel free to share.
All right, share screen. Can you see it?
Not yet. Yes. Now I can see it. Yes.
Okay.
Would you like to make a, yeah.
Okay. So this is a video that that shows AI in action. You'll see some numbers over here on the left, and I'll explain those as we go along. So, and then I'll kind of pause this too as necessary. But the first thing is we have an AI that knows when we start the procedure. In other words, when the scope has gone in. And it's now in, and you can see right up here, it's marked the start time. You'll see little boxes. Well, this part here is recognizing the cecum. You can see this number up here going up, went up to like 80%, and then it marked the cecum time. So that's the top of the colon. So now the algorithm knows when we reach the top of the colon. Here it is recognizing polyps, and the tool that we're using. See, it's recognizing snare. And here we are removing a polyp. And then
Wow.
it can find more than one polyp at the same time, such as on here, there's 2 polyps. And it even can tell what kind of a polyp it is. In the case of those last 2 polyps, they were serrated polyps. Here's the AI running side by side with the native video, and you can see it almost undetectable lag. So even though the video is running through an AI machine and coming back up to that video screen on the left, it still looks the same as the one on the right. Here's an example where it's finding 3 polyps at the same time, and there's 2 different pathologies here. The pink one on the left is an adenoma. The yellow one in the middle and the one on the right are serrated polyps. The one in the middle is actually a sessile serrated polyp, which is another type of a precancerous polyp.
So Dr. Kans,
Yeah.
so in this video, you just tell us like AI colonoscopy can detect not just finding out polyps, it detects different kinds of polyps and whether it's cancerous, and even if it's cancerous, this type is different than this type.
Correct. So there's 2 main categories of polyps in the colon. There's the adenoma category, which are clearly precancerous. And then there's the serrated category. Over half of the serrated category is composed of hyperplastic polyps, which are not thought to be precancerous at all. And so you could find 5 hyperplastic polyps, and that person could still come back in 10 years because those polyps don't really count toward their risk of getting a colon cancer. Whereas the sessile serrated polyp, which is the second major category of serrated polyps, like this one here, or here, I think I was using my mouse pointer on the wrong screen, is precancerous and can actually convert from the polyp stage to a cancer stage in a relatively short period of time, like in a year.
That's the aggressive one.
Yeah. And so we're just finishing up developing an AI that can distinguish the two different kinds of serrated polyps.
So in here, how AI detect polyps, whether it's cancerous or the benign, based upon size or the shape or the combination?
We don't, when we trained our AI based on the known pathology of about 20 some thousand polyps, images of those polyps. So the AI kept looking at ones that the pathologist called adenomas and kept looking at ones that were called sessile serrated polyps and the ones called hyperplastic polyps, and it learned the features of those polyps. We don't have a real way to reverse engineer how it learned, but human beings who, well, I should say, seasoned veterans who do a lot of colonoscopy do have a pretty good ability to look at a polyp like this one, for example, and say that's a hyperplastic polyp based on the fact that it's pale, it's rather bland. This one's a little pinker, and it does have some features of the surface that you can't really appreciate here that tell us that that's an adenoma. This one has a mucus cap on it, which tells me that's a sessile serrated polyp. And apparently the AI learned these same features by itself.
Wow. So more data you collected and feed to the AI colonoscopy, the AI becomes smarter and smarter and more accurate.
Correct.
So what's the accuracy with this current AI model?
The accuracy for polyp detection is 99.5%. That's the area under the receiver operator curve. And for pathology, it's about 94% concordant with the pathologist.
Wow, it's already way good. It's really amazing accuracy already.
And the one other algorithm we have running here, so we know when it's in and out, we know when it reaches the cecum. This bar here is recording the quality of the prep. So, and it's based on a standardized scoring system called Boston Bowel Prep Score. So this particular view is seeing a very well prepared colon. The bar is all green. And so it can mark our times when it went in, the cecum, when it comes out, and then pretty much can write a report for us.
Wow, so AI can write a report for physicians.
That's
so
our
then,
goal. That's our goal.
Then you read it. So that's why you mentioned like before nurses can put the information in, but now it's AI put the information in. So that saves tremendous time for physicians and nurses and other healthcare professionals. And so that really saves time for you and others to really focus on patient care.
Yeah. And it's tracking our adenoma detection rate, isn't it? It knows.
Wow.
Yes.
That's so amazing. Oh my God. Thank you so much, Dr. Karnes. Thank you for your time.
You're
and
welcome.
I hope we can talk again in the near future with updated research results and updated information about DocBird's AI colonoscopy and other AI algorithms and devices.
Thank you so much.
Thank you. Let me stop recording in here. Okay, so